Our next speaker is Dr. Selma Clames. Dr. Clames is a retired board-certified anesthesiologist who is also a polio survivor. And this is her own self-written bio. She states, somehow she made it through medical school and graduated in 1965 from Baylor College School of Medicine. I had a chance to speak with her for a few minutes and somehow doesn't quite capture it. She's an amazing woman. For 18 years, she was chief of anesthesia at UCLA Olive View and was clinical professor of anesthesiology for UCLA Medical School. She became curious about why polio patients were so concerned about their anesthesia experience and gave her first talk at a polio conference on this subject in 1994. She'll discuss an important aspect of anesthesia care for post-polio patients, specifically how to get ready for surgery and anesthesia today. Dr. Clames.
Thanks, Rob. Just be sure I've got everything here. Oh, well, good morning, still morning, and I'd like to say thank you very much for inviting me to speak, and thank you for coming after lunch. I know that was an effort. There is a handout, a very brief collection of information about some of the points I'll make, and I decided to give this out so that you won't have to write anything if you decide you want to remember, and these I consider are the most important points. The objectives I'm going to aim for today: what do we really know about polio and anesthesia? Anesthesia, surgery in the lungs, how does this all mix together? The respiratory complications of having anesthesia. Who's at risk for post-op respiratory complications? How to plan ahead, and this is extremely important. This is where it all starts to get a good outcome. And then I want to mention the real risk when you have an operation, and I think you'll be surprised at what that is. Well, you've come today hoping to get a 1 or 2 sentence piece of information like don't give muscle relaxants or don't do this. You want to tell the anesthesiologist. And I want to say it's not that simple. To know what really works, what's effective and safe for patients, we have to have published studies. And this would be a study that asks the right question, like how do polio patients do in terms of post-op respiratory complications after anesthesia? It has to have an adequate size for the sample. It has to be carefully designed. There needs to be an astute statistical analysis. And it needs to be published preferably in a major peer-reviewed journal like the New England Journal of Medicine. Other people would then confirm the study or argue against what you found. And then there would be feedback as practitioners begin to use what you advocated in your article. Well, what do we know about anesthesia and polio? This is going to be a little disappointing, I'm afraid, because the answer is not much. And so it's not possible to make these specific one-sentence pronouncements that everybody wants. It's much more complicated than that, and everything has to be carefully integrated. This is what we know about polio and anesthesia in the published medical literature. There are 8 case reports. In 3 of those, there were care problems. For example, a large dose of narcotic was given to a patient, and the patient was taken to their room and not observed, and of course was found unconscious, brain dead, and did not recover. That's not a polio issue. That's a care and the process of care problem that the patient was not observed after getting a respiratory depressant. There are 2 theoretical studies. These are based on what we know about post-polio syndrome. And one is on surgery. This is general surgery. This is pretty good, and it's in the journal Anesthesiology. So it was by anesthesiologists and neurologists. There's one on dental anesthesia. I finally was able to get a copy of this, and it's very outdated. So I wouldn't necessarily recommend it. There's one population study from Brazil, which came out about 2 years ago. However, there are no controls. It's only the polio patients. And so they didn't compare to normal patients. And very interesting, they had 123 patients having, I think, 160 some operations. And the median age of the patients was 32. Now, in the United States, our median patient age for polio patients coming to surgery would be in the late 60s to early 70s. So it's a very different group of patients. Also, in terms of serious disease, only 3 of the 123 patients had any serious disease in addition to their polio symptoms. And again, that's not what we see in the US. Because our patient group is older, they frequently have the diseases of aging, heart disease, high blood pressure, diabetes, and so on. So we in the United States can't really learn much from this study. Finally, the only operation or types of operations done were orthopedic surgery, usually peripheral orthopedic surgery. And so the patients that we see are having chest surgery, back fusions, aortic aneurysm repairs. Again, it's a whole different ballgame than this reported study. So we really don't know very much. And it's hard to make these 1- and 2-sentence pronouncements. Also, I hope you'll see as I go along that many factors affect how the anesthesia should be done. There is one thing that we do know, and which is good, and this was done in 1990, and we learned that post-polio patients are more sensitive to the non-depolarizing muscle relaxants. Whoops, I lost a slide. And this shows the electrical response to different types of electric stimulus, a twitch or a long tetanus, and the depression to 50% of the muscles contractions in normal people and in polio patients. And you can see that it's about, the polio patients are much more sensitive. And it's interesting, by the way, that this effect, the duration of effect of the muscle relaxant is the same in normal patients and post-polio patients. So if you give half the dose of the muscle relaxant to a polio patient, you'll end up having the same duration of effect as a normal dose in a normal patient. And this information is finally getting circulated. All your anesthesiologists should be aware of the sensitivity of polio patients to the curare-like muscle relaxants. Well, I've told you what we don't know. Now let's talk about what we do know about the lung during surgery. This has been extensively studied, and actually a lot of very good information has come out about how normal people do during surgery, and that's what we're going to have to talk about right now, and then put polio into the equation. I'm going to mention what happens to the lung during surgery, post-op respiratory complications, and then discuss, regular patients versus polio patients. I'm going to take just a quick break for some water here. Sorry, my voice is fading today. Anesthesia and the things that we do can affect all parts of the respiratory system. We'll focus on the lung, but I just want to mention that in the upper airway, we can cause trauma occasionally when we place the breathing tube. When we place a breathing tube, that could trigger bronchospasm. There can be all kinds of depression of the cilia. I think that's been mentioned already. The cilia is needed to take sputum out of the respiratory tract, and we actually put the cilia to sleep. They don't beat as fast, and so clearance of secretions is very poor during anesthesia. And I'm talking general anesthesia now. We'll get to the lung more completely in just a minute. The diaphragm also changes its shape and its function during anesthesia. And many of the things that we do affect the muscles of respiration, and they're not as effective as they are when you're awake. This is another diagrammatic scheme of the alveoli, which were mentioned in the first talk. These little distended sacs of air with fine capillary networks around. on the outside, delivering CO2 to be removed, taking up oxygen from the air that you're breathing. And every patient, I can't say it here nearly, but I think we can probably say every patient who's anesthetized with general anesthesia gets atelectasis or collapse of the alveoli. They're not filled with air anymore. And quite often, the circulation of blood, the perfusion of the alveoli continues. And so we have blood going by, but no ventilation. And so there's what we call a mismatch of ventilation and perfusion, and this leads to lower blood oxygen levels. It doesn't affect CO2 because CO2 is much more soluble than oxygen. Now there are other, let's see, I'm losing, oh, there we go. There are other things that happen besides anesthesia to affect lung function, and one of the main things to think about is the position of the patient. Typically, in the OR, you would be supine as we are in sleep. And the dependent part of the lung here is different in perfusion ventilation than the upper part of the lung. And so the people that want to have their studies in the supine position, this would be a reason for you to have this so that we know what we're going to start with. Now, you might also be in the lateral position. This would be a position that would be used for chest surgery or adrenal surgery and so on. We can also do it lateral with the legs down. And now this is a whole different ball game than the straight lateral because the legs are below the heart, and so blood is not returning well to the heart. And so perfusion of the lung is not as good as it is in this situation. So we have to be very much thinking about what's happening to ventilation and circulation when we drop the legs in this position. You might also be in lithotomy position, and this doesn't look too bad. Here the legs are elevated, and so blood is drained from the legs into the central circulation. Good perfusion of the lungs, you would think. But typically in lithotomy, we drop the head down quite steeply. And so that affects the ability of the diaphragm to move up and down. And we can see quite a drop in our oxygenation when we put the head down. And this is especially true in obese patients. And you might be prone on your face. Now our ventilation is better in the upper part of the body and worse in the lower. And these supports may be compressing circulation and return to the lungs, and blood pressure may be sagging. And then finally, you might be in the sitting position. And this can cause all kinds of problems. You can see diaphragmatic excursion would be really pretty, I want to say, cramped, because there's not a lot of room for the diaphragm to move back and forth. And so there are other things besides unique positions that affect what's happening in the lung. The surgeon opens his chest and puts their hand in to squash the lung down. And that is a very exciting time. A retractor that's in the upper abdomen, say right under the rib cage, might be pulled up toward the head, and that would push the diaphragm up and compromise ventilation and perfusion. Many of you have probably heard about laparoscopic surgery. Has anybody here had a laparoscopic surgery? Okay, good. In order to operate laparoscopically, it's necessary to distend the abdomen, and the surgeon puts in a big trocar in the abdomen, and they inflate the abdomen with liters and liters of carbon dioxide gas. And so the abdomen becomes incredibly distended. Then we tip you head down so that the intestinal contents are sliding up. In some cases, we go the other direction if they're going to be operating in the very upper part of the abdomen. So, and the CO2 can affect perfusion, the return of blood to the heart, and also it's dumping a load of CO2 into your body. And the CO2 gas is used for a number of reasons, but what we do is increase your ventilation during the time that this is taking place. You might have heard about robotic surgery. That's the latest kick, and it's very, very effective in terms of less pain and more precision in operating. But there's some interesting things about it. For example, it's most commonly used in prostatic surgery, and that is done in the steep head-down position, and it takes like 7 hours. And so at the end of the case, the head is very edematous, as is probably, no doubt, the top part of the lung. One other final thing that we would think about as the operation proceeds is, what if one lung ventilation is needed? It's not unusual to ventilate only one side of the lungs for particular surgical operations. And when we start one lung ventilation, it's very fascinating that this initiates an inflammatory reaction at a chemical level in the lung that's compressed. And this can be of great significance as the recovery period is taking place, and especially if one lung ventilation is needed for a long time, the process gets established, and it's it gets to a point where it can't easily be processed and dealt with by the body. So there are other things besides anesthesia, the surgical positions, the operation, and then there's you and what you come with: obesity, lung disease already, probably many in this audience, and scoliosis. And this would be a picture of many of us, I'm afraid. And you can see that the ventilation on this side would be much less than normal. And I want to also point out that getting you into some of those surgical positions would be very difficult, because you're asymmetric, and the usual ways that we position people can be very difficult in the polio patients. Another piece of that is that the bones underlying our weak extremities are osteopenic because muscles aren't pulling on the bones. They don't have as much calcium as normal. And it has happened that extremities have been fractured while we're trying to position a patient with polio. So it's necessary to be extremely careful with patients like this. So in summary, nearly every patient having general anesthesia gets atelectasis. And notice I said general anesthesia. Is this a reason to have regional anesthesia, like a spinal or an epidural or a nerve block of some kind? Yes, it is. The disorders are not nearly as bad in terms of atelectasis. It depends on the operation, but anyway, regional anesthesia has a lot to say for itself favorably in this setting, and the problem is that not all operations can be done with regional anesthesia, and there are also some surgeons who cannot operate under regional. We have, when the atelectasis takes place, the VQ mismatches, lower blood oxygen levels, our positions, the operation, and then the pre-op problems. Now, I want to say, console you with the fact that we have absolutely fabulous monitors nowadays, and while you're asleep, we're able to monitor every piece of your physiology, end-tidal CO2, the oxygen saturation, SpO2. We can do all kinds of pulmonary function tests now during the case, actually do flow volume loops. And so we're able to diagnose these problems and treat them as things go along. The problem becomes the post-op period. Well, I've mentioned before the possible trauma, bronchospasm, and so on, and I just want to add a few more points to what can happen. There can be aspiration into the lungs. This could either be secretions before the breathing tube is placed. There might be an infection in one lung that goes to the other. There might be bleeding that occurs and gets into the lung. We can trigger bronchospasm, as I mentioned previously, and this can also be triggered by the aspiration. It can be difficult to treat, but with our new monitors, we can detect it soon and treat it more effectively than in the past. The continued atelectasis post-op, for the average patient, it takes about 3 days for the lungs to become normal after a major abdominal operation. And so it's a process that has to resolve. And this is the time when a lot of patients get into trouble. They have some atelectasis, they're given a heavy dose of narcotics, they might not be well observed or monitored, and they'll become unconscious, or some other problem would happen. So expect a 3-day process at least. And then respiratory failure. If you have the absolute minimum of respiratory musculature, it's going to be difficult for you to overcome some of the problems that can show up post-op after a major operation. Just a couple of other things. It has been reported vocal cord paralysis has showed up after the breathing tube has been taken out of a post-polio patient. And my guess is that this patient had it before, and something just tipped him over during the operation, the presence of the cuffed endotracheal tube or something like that. But it has been reported, and one of the things that I want to just mention is the need to always know your cord status before you come for a major surgery. And diaphragmatic paralysis, I'm going to mention this more at the end, but many people are dependent on the diaphragm, and intercostals, which were mentioned in the first talk, and things that we do can severely impair these things. And you need all of this going for yourself when you come for anesthesia. Well, who's at risk? We know this from normal people. If you're having chest or upper abdominal surgery, if you're over 70 years old, if you're morbidly obese, morbid obese means twice your normal body weight, history of smoking, and I hope nobody smokes in this room, and then pre-existing lung disease, and probably many of the people in this room have that already. When it's time to have an operation, I hope that you're already getting good medical care by a regular physician and by a pulmonologist. And I would hope that you would see this person at least once a year. And the problems of coming once a year were mentioned previously, but it's just essential to be, even though you're not having problems, be monitored to look for the detection of these problems early on. And each visit would include a good history and physical, perhaps lab tests, pulse oximetry on room air, and then at least yearly, more frequently in some of these clinics that we've been discussing, end-tidal CO2 and maybe arterial blood gases, pulmonary function, and evaluate the cough function. And as an anesthesiologist, I wasn't aware of how to measure cough strength, but that's a very important thing. And I think that a lot of the problems that we see post-op come from not being able to cough adequately. And in relation to that, I forgot to mention that cutting the respiratory muscles, for example, to approach an abdominal organ, can really cause a lot of disruption post-op because you don't have the strength. It hurts every time you try to breathe. And so it's very important for the surgeon to think about, can they not cut the muscle? And then for the anesthesiologist to think, how can I give the best pain relief to this person so that they can breathe adequately in the post-op period? Anyway, these would be your normal things that you would have in place. And then some problem comes and you're going to need an operation. And this, I know this sounds really, I want to say, simple and in a way stupid, but it's critically important. Many of the anesthesia complications that have been presented to me as being due to anesthesia are actually surgical problems. And the surgeon will never tell you this, of course, but they are indeed surgical problems. And so you have to really pay a lot of attention and do some research yourself. The first question for a surgeon when you go to visit about an operation, what exactly would the operation be? How urgent is it? It's seldom that you have a truly urgent surgical emergency unless you're in a car accident or something like that. There's nearly always time to prepare. What hospital will he or she use? And this is probably the most important determinant of how you're going to do in this operation. And notice, by the way, I put he or she. There are a lot of women surgeons now, and it's a different ball game. So they're not quite so many temper tantrums. And it's much more collegial, that kind of thing. And then I thought that did the job. What are the complications of the operation? And I can tell you that the surgeons don't always cover everything. And we're going to get to what you should do about that in a minute. What is his or her training for that operation? Did they take a course in laparoscopy or whatever? And for the new modern operations like the robotic and the laparoscopic procedures, they do take training courses and they get certificates, and they will always know how many of what they've done. And volume is what we want. And then how many has he or she done exactly, because the more you do, the better the results. And then, does that surgeon have any outcome data on his operations? Many surgeons do, and this is the great advantage of going to places that are academic institutions, because they're measuring these things, and each surgeon is compared to other surgeons in the department and to the national level of surgeons, the American College of Surgeons, and academic institution gets this kind of data, and you can see where you and your department stand. So, and this is the kind of information that's needed because there is a tremendous variation in surgical skill. Another question that's important, will any residents be involved? Now, residents need to learn, and it's just we don't want to give them, I want to say, too much responsibility, and that is especially true in the ICU because they don't always know everything they should know, or it might be an unusual situation that needs a more senior help. What kind of anesthesia is usually used? Some surgeons can't operate under local or regional, and so everybody's asleep. Will you need to be in an ICU post-op? And will you need post-op ventilation? Some operations really require post-op ventilation for even an average patient. And for example, a long intra-abdominal operation with a lot of blood loss, we're not going to allow even a normal person to breathe on their own initially. They're going to have to, we're going to take away the work of breathing by assisting ventilation for some time, depending on how that particular patient does. Well, after visiting the surgeon, you want to go home and go to your computer. And if you don't have a computer, get your grandkids or your kids to help you with this. And the first thing to do is check out the surgeon. You'd be surprised. I'm talking California now. I know there are some out-of-state people here, but each state licenses physicians. In California, this information about the physician license is publicly available on the web. And are they currently licensed? Where did they go to medical school? Did they go to UCSD? Or did they go to someplace in the Philippines? You know, you have to take a look at that. How long's it been since graduation? You want some experience, so you would hope that they've been out for a while. Have there been any disciplinary actions? And this information is available, including what the allegations are and what the medical board's action was. And again, I want to just say, you'll be surprised sometimes, and you want to find out for yourself. And in many, there's some websites that rate physicians, local physicians, and the consumers say, oh, he's a nice guy or whatever. You need to forget those because they're not correct. And I can tell you some bad situations. So how the physician comes across to a consumer is not what you need to know. You need to know what's happening at this end. Now, I had mentioned academic hospitals that have teams of people that work together. If you go to an academic institution to have your operation, like University of Washington, UCSD, you'll be guaranteed that all of this is okay. Because in order to work at that hospital, they have to have all those things in place. Everything has to be good. But if you go to a smaller hospital, and this is where I've seen some real significant problems, you don't have this kind of information easily, and you have to go and get it yourself. But in this situation, the system does it for you if you go to an academic institution. And then check out the operation on the web. What really are the complications of that operation? And then if there are significant complications, can you deal with them? One of the worst questions I had was a patient who became paralyzed after cervical spine surgery. And the family said, well, what could we have told the anesthesiologist to prevent the paralysis from taking place? And this isn't a surgical, this isn't an anesthesia issue, this is a surgical issue. And cervical spine surgery comes with that chance. And so either they didn't hear it, or when the visit was made to the surgeon, or it wasn't told to them. So you need to, on your own, look it up and see, can I live with whatever this potential problem is? And also look at the chance for that kind of thing happening. And then a final thing, check out the hospital. And you'll see why we need to know this in just a few minutes. But it's extremely important to be sure that hospital's got it together. The Joint Commission for the Accreditation of Healthcare Organizations visits every hospital in the country that gets Medicare money, and checks a whole bunch of things, lots of nitpicking things, but most of them important. And in California, the state's Department of Public Health comes with the Joint Commission team and does their survey. They have slightly different rules. And you can find out, is the hospital accredited on the Joint Commission website? And the handout has the web address for that. And also, I mentioned about our state. The state also publishes that information. Things like how many complaints per year, what were the significant problems, were they accredited, and how many deficiencies did they have? One of the hospitals I looked up when I was getting ready for this talk was here in San Diego, and there was a hospital that had 56 deficiencies on their accrediting exam. That's way out, and you might really want to think about whether you would go to a hospital that had that many deficiencies. The good thing is that it got better in subsequent years, and so they made a lot of progress. The reason I'm so concerned about hospitals is this graph. There's a governmental agency, the Agency for Healthcare Research and Quality, and in 2002, they put together a look at the different risks, safety risks that you might be exposed to. And this is the number of events per million opportunities. So per million units of blood administered, you'd get the 0.7 chance of getting AIDS from the blood. Per million airline passengers, there's 2.4 chances that you would possibly die in an airline crash. For anesthesia, 7.5 per million anesthetics. For MVA, motor vehicle accidents, 187 per million drivers. It's not per miles, but it's drivers. And for hospitals, 208. And this is really quite shocking. About 3% of patients that are hospitalized have a significant event, an adverse event it's called, getting the wrong drug, having the wrong operation, and so on. And these are events that lead to death of the patient. And it's really quite unsatisfactory. A major effort is being made to improve this situation because it works out to be about 44,000 to 98,000 patients per year who die from an error during hospitalization. So this is why I want you to go and look at the hospital and be sure that everything's okay. And again, this is another reason to go to a major hospital for your surgery. It's not quite as convenient as your local hospital, but it's safer. And this is where all the concern should be. It's not here. It's here. So worry about the hospital, because that's what the real problem is. Well, after you've seen the surgeon, checked them out, checked the hospital out, you need to go back to your regular MDs, your regular physician, and the pulmonologist, and ask the question, can I improve my lungs preoperatively? Stop smoking 3 to 4 weeks before surgery, at least. Preferably don't smoke at all. Bronchodilator medications, if that is an issue for you. Antibiotics, if infection is present. Chest physiotherapy or bronchial drainage. And then it's very important to delay elective surgery until your optimal status is reached. And that should be optimal by measurement, by pulmonary function tests, by SpO2, the oximeter readings, and so on, because everything's got to be perfect for you to have a satisfactory outcome. Now, there's been a question, what should I tell my physicians, preferably the anesthesiologists, but it's often difficult to reach them preoperatively. The main thing they need to know is, did you need an iron lung during the acute disease, and how long were you in the iron lung? 2 weeks or 6 months. That tells a lot about what kind of muscle weakness you might be left with. Did you need a trach when you were in the iron lung? And the trachs for iron lung patients were typically done quite high in the neck for logistical reasons, and occasionally there are some surprises when we intubate. There might be a little web or something interfering with the passage of the breathing tube. Do you use a ventilator now? For example, if you use it at night and you go into the office without the ventilator, be sure to give them that information. Do you have reflux, sleep apnea, vocal cord problems? All these are important to the anesthesia management, and also your general physician should be aware of all of these. And I want to just put a gold star by vocal cord problems, because I'm seeing more and more of this problem in our patients. And people will come up to me at some kind of post-polio session, and they can just barely whisper. And so they have a vocal cord weakness probably, and need to be worked up. And that was previously mentioned, and the need to have an examination if you have problems, by having the ENT doctor look down the nose at the larynx, and also they're able to do muscle neurologic studies by looking at the muscles of the larynx and the neck during the time you're speaking. It's not a lot of fun, but it's very important. What's your ambulatory status? If you don't walk at all, your circulatory reflexes aren't quite up to a normal person's. Have you had any previous problems with anesthesia? Many of our polio patients have had like 14 operations or more, especially in childhood. at a time when anesthesia was very different. It was either by mask. Most of the time they were held down, and there are a lot of bad memories of anesthesia from childhood, and then other problems that you've had as an adult. And then how about your diseases of aging? This keeps happening time and time again. When I get consulted, the people will ask questions about their polio and so on, and then I say, well, do you have heart disease? And well, yes, I had a heart attack, you know, a couple of years ago. And then, do you have any angina? Well, yes. And it turns out they've got an implanted defibrillator on top of that. And so their risk is heart disease and a heart attack during the anesthesia and operation, as opposed to any kind of polio problem. So you have to, you know, weigh the risks. It's not always polio as a risk. And then, are you very sensitive to pain? You all know that some of us are very sensitive to pain, and fortunately anesthesiologists have tons of great tools now to help you with your pain in the post-op period. In terms of post-op care, will you need a ventilator post-op? What kind of ventilator? This is something that needs to be discussed with a pulmonologist, and also who's going to be managing this. And this becomes a very difficult thing, and I hope that we can have some discussion on this later. Making the transition from your pre-op ventilation through an operation and to post-op recovery is very difficult many times, and not just in terms of what's happening with the patient, but in terms of the systems. Can you bring your ventilator to the hospital? I mean, they don't like that to happen. And so there are a lot of issues, and that's another reason to go to a place where there's a team approach, like an academic institution. And many institutions today employ hospitalists to manage the post-op recovery in the ICU of such a patient needing ventilation. And these are doctors employed at the hospital just to work on an hourly basis in the ICU or sometimes on the floor. And it really complicates things if it's not your pulmonologist who can come in and help make this transition. And so you need to find out ahead of time, are hospitalists used for ICU care? And be sure that they understand all your previous problems. And there is often a record problem in this situation. Post-op pain management, this is tremendously important. The first thing is that at the time of surgery, the surgeon should inject local anesthesia at the incision site, and also there are other areas that he or she can inject as things go on during the operation. And our newer local anesthetics will last up to 48 hours. So that's a start. Anesthesiologists managed epidural or intrathecal narcotic techniques are critically important if you're going to be having a great big operation. I'm talking chest surgery, big abdominal surgery. It's not quite as critical for things in the periphery, but this technique is the safest, I believe, and also gives the best outcome. And then finally, it's common to see patient-controlled analgesia in use. It's a little pump with a narcotic drug that's delivered continually to you, and also when you press a button, you can get a bolus. There have been a number of serious problems with this technique because of the observation on the floor. And I want to just urge you to be very careful about this. As you know, if it's offered to you, and it's very helpful to have somebody with you who can be sure that everything's working correctly. The one proven thing that we know that works to prevent post-op respiratory problems is incentive spirometry, and so it's very important to get the instructions for this before surgery and to follow them carefully during the wake-up period. And I can't emphasize that enough. It's inexpensive and it's effective. I have just a couple of miscellaneous points. Many polio patients have shoulder problems because of our use of devices. And So they come for shoulder surgery. We'll see that in just a minute. One of the things that's commonly done for shoulder surgery is a nerve block of the shoulder area. It's done usually above the clavicle, your collarbone, or it can be done below the collarbone. And this gives nice anesthesia of the whole shoulder girdle. It's done before surgery, so it helps the surgeon. And then in the post-op period, you're able to do the exercises and the movements that are needed to get you on the rehabilitation road. And this shows the patient's head is up here, shoulder here, the collarbone here. The problem is that the phrenic nerve is running right in here, the nerve that innervates the diaphragm. Now, we only do these shoulder blocks, supraclavicular, infraclavicular, on one side. Don't ever let anybody do it on both sides, because then most people get a diaphragmatic weakness when the block is done. So pre-op, if you're very marginal in your ventilatory capacity and you need your diaphragm function in order to get breathing again on your own, you don't want to have this in place, because the drugs that we use are going to last 48 hours. And so you'll be without a diaphragm for some time. I want to just point out the beach chair position about use for shoulder surgery. Patient head, shoulders fully exposed here so the surgeon can rotate it around, and the knees are bent up here. And this position looks pretty innocuous. It looks pretty comfortable. But the problem is shoulder surgery involves reaming of bone with an electric drill and up in here. And there's a lot of blood loss when that happens. And so orthopedic surgeons, being what they are, tell the anesthesiologist, drop the blood pressure so that I don't have as much bleeding, less blood going up to the shoulder. And what has happened in way too many cases is that there's not adequate blood flow to the brain in this position, because the brain is up above the heart. And many healthy people have not woken up after this operation. So you want to be extremely careful if you have shoulder surgery. And you can get a lot of mileage out of physical therapy in that area. So think about it very seriously. It's a relatively high-risk operation, and especially if you're not going to have your supraclavicular block. So I want to just end with, I want to say, a synthesis of what it takes to get a successful operation. You've got a patient, and the patient has diseases, post-polio syndrome, diabetes. You've got a history. Maybe you had problems before in the past. There's some psychic issues, in my opinion, about being in the hospital. After you've had polio and you come back, it's very stressful. And then we have an operation, and the operation has a need for a certain kind of anesthesia, a certain position, and so on. And so these two things are playing on each other, and we've got to work out, what is going to be the best for that patient. And then we've got the surgeon and the anesthesiologist, and they need to cooperate. And one of the fun things about anesthesia to me is being a team with the surgeon and the nurses, and you all work together, and it becomes very theatrical. It's kind of like a play taking place, and everybody knows what to do. There should also be arrows going this way, but I didn't want to have too many arrows. It's like a pot of soup that's put together with a whole lot of different ingredients that makes a perfect product in the end. And I hope that, your own experience, you can work out this kind of I want to say collegial teamwork approach. And it's very important also to not be confrontational with the surgeon or with the anesthesiologist. I see this from time to time, and they get alienated. You really get a lot more with a question and saying, well, what do you think? And you'll come out with a much better result overall. Well, we've discussed these objectives. What do we know? Not much. Anesthesia, surgery in the lungs. Anesthesia makes lung function worse. Respiratory complications we've described, and that includes some of these upper airway and the muscular problems. Who's at risk? Over 70, obese, upper abdominal or chest surgery. It's extremely important to plan ahead and take your time, get it all together. And then we've discussed the real risk when you have an operation, and that's the hospital. And you've got to be sure that you've got the best hospital that you can get. So I'm going to end by showing you where I work. And when you come to the high-tech operating rooms, please have confidence. Modern anesthesia today is extremely safe. It's made incredible quantum leaps. It's all different than when, well, actually when I began. I was going to say when you had your operations as a child. And it was different then, it was different when I started, and now it's incredible, very interesting, wonderful specialty. There are a lot of real dedicated, hardworking people in this, and they want you to have the best outcome possible. This is the view from my kitchen window. Now that I'm retired, I look out at that a lot. And I wonder, do we have time for questions, Brad?
Limited to just a couple of questions.
Okay, so I guess I'll take 2 questions if anybody.
My question would be,
Get you a microphone quickly because we're capturing this for recording purposes. Thank you.
I have a urologist that says I have to have bladder surgery and get cut open in the stomach, and a pulmonologist that says if they do that, they'll probably intubate you, and I can probably never get you off the intubation. So don't do it. So,
Well,
how do you get 2 doctors to agree on something?
Well, you might need another doctor. Doctors have different opinions, and it depends on exactly what they're going to do. What kind of operation? If it's a radical prostatectomy,
Yes.
that's yeah, okay, that's big, and so you might want to consider other options for therapy. So I would consult another urologist who is very knowledgeable. For example, radiation might be useful, and that would avoid the need to have you asleep. That's a big operation, a lot of blood loss. You know, it's not easy.
Thank you.
After you've had a major surgery and...
Well, just because of the effort of breathing for the long period of time, we're talking 4 or 6 hours, and you would tire out if we weren't breathing for you, and we need the breathing to protect your airway from the secretions and so on, and also to decrease the work of breathing for you. And I forgot to say that, but during the operations, we breathe for you, and we know because of our monitors exactly how we're doing, and we also measure blood gases and so on. We're very sophisticated about what's really going on. It's the post-op period where you get into trouble. And
One more quick question.
In the post-op phase, if you've had one of those major blocks done, localized, and it usually lasts 24 to 48 hours, I noticed when the block wears off, pain management in the initial phase is a major problem. You have to go into heavy sedation, the person hits the pump button several times and stuff, and that compromises respiratory. Is there a way to get ahead of that before the block actually wears off?
yes, it's not going to be ideal, but we use the anti-inflammatory medications and add then smaller doses of narcotics, and hopefully not such powerful narcotics. It's not easy to do blocks at that stage, 24, 48 hours later. But at least during the worst pain, you have some removal of pain from our techniques. So there's not a perfect answer for that. Many hospitals today, especially academic hospitals, have pain services run by anesthesiologists, and they will see every patient that's on you know, whatever kind of pain therapy, and they'll check them usually twice a day, and you can, you know, discuss this with them. I'm worried about what's going to happen when this block wears off, and they're very knowledgeable. We have lots of tools today, so in general, it's not too much of a problem.